on your intake form, but they can lie, they can embellish. So what did I tell the two of you last week? You asked them one more time, if it's a female patient, what did I ask?
You asked them again, right?
You asked them again, and the initial on your tablet, I asked the patient, the response was no. That's your document that says, get off my case, I asked her, she said that she wasn't pregnant, it's documented. That's why I took the x-rays. If you take the x-rays knowing she's pregnant, what should happen? I know malpractice, no x-ray. You have to say to the doctor, I'm sorry, or you're the doctor, but if your CA is taking your x-rays for you, okay, she has to let you know that she's pregnant. Okay? No ifs, ands, or buts about it. Never mind the hospital has a different set of rules, okay? That's how important that is. Okay, the first one we're taking at source image distance. The projector is the X-ray tube. It's at 40 inches, and I can slide the projector back and forth, and we'll show you that in the lab. The area that you expose is no bigger than clip pad, board pad. Pad is 8 by 11 inch paper, and we'll show you in the lab how that works. So you're gonna make a lit up area that's 8.5 by 11, but where's the spine? The spine is in the middle, okay? So we don't need this full 8.5 by 11 area that's exposed. We can make it smaller, and it's easier to show you that in the lab. What do we mean by tilt? We don't want this unless they're antalgic. If they're antalgic, that's how we take the x-ray. If they rotate for a reason, we take the x-ray like that. If not, eyes straight ahead, and you're gonna make sure the head is level. The area that we're gonna expose is no bigger than the mask we've been using for COVID. And we say to the patient, can you open your mouth nice and wide? And we aim the horizontal part of this, the angles of the mouth or the bottom of the top teeth, okay? Now, in the meantime, before we do that, we have to make sure this is set at 40 inches. If I'm standing here, I have to make sure the marker is in place. Which marker do I want on this side? Right? Which marker do I want if I don't have the right?
The left.
I can use the left. And then this thing has to be moved up and down so it corresponds, so that this X and the capturing device or the film matches where we've aimed. And we'll talk about that and show you how to do that in the lab. Okay? Midline of the table, I've just shown you what that is all about. What that looks like, diagrammatic, okay? And this is where the central ray goes, and it's in, the area of interest is the first and second cervical vertebrae. They're called atypical. Why? Because they have different pieces compared to C3 through 7. All right? We're interested in this odontoid or dens. That's the part that hit the steering wheel. And it doesn't hit the steering wheel straight on. There's usually a little bit of rotation. And that rotation disrupts the vascular arcade here, and it fractures the cortex. There's different types of odontoid fractures, but for our purposes, that's what you need to know. Okay? So I'm saying to you, that you get in your history, my head hit the steering wheel. What view do I want to make sure you have? A good open open mouth. Now the challenge is I can't open my mouth bladder. That's what you can do. That's all you can do. You take the x-ray with 4 to 6 weeks of chiropractic care. They should be able to take that view, but we also have the ladder. Okay? Now we're gonna go through a process where you have to be comfortable with your parts of the cervical vertebrae, but that's for another class. Okay, what do we mean by collimation? Collimation, I'll show you an example of collimation. This is collimation, that's the edge. The spine's in the middle. You've set up your area that's exposed to be the sheet of paper 8.5 by 11, but we're gonna make it smaller because the spine is in the middle. And then it's incumbent on you to put the patient's spine, and we'll show you how to do that. Okay, so that's really in the middle. I'm just using that to show you what collimation looks like. Okay, now why do we notice that there's a difference? This central ray is tilted up. What do we mean by the central ray? This part of the X, and we'll show you in the lab, has to be at the thyroid cartilage. Now why is it tilted? Because you have a lordosis, right? Some of us have a straight cervical spine, some of us have an exaggerated lordosis. And that's why we take advantage of this We tilt it 10 to 15 degrees. We'll show you how to do that up towards the head. Okay? Everything else stays the same. Now, why are we interested in doing that? Not only because of lordosis, you've heard of uncinate processes.
Mm-hmm.
Because you tilted the tube, you see the uncinate processes optimally compared to if you hadn't tilted the tube. There's a reason for tilting the tube. The lordosis and the uncinate processes, you'll hear me calling them Luschka joints. That's just my background. Still at 40 inches, so that's the second view. And then that's what it looks like. These are the uncinate processes. The disc is in the middle. Think of it as a Krispy Kreme donut, jelly on the inside. That's your nucleus, annulus. These Luschka joints are the side lateral flexion containment processes. All right? Now, why do I emphasize them? Because if your disc undergoes degenerative change, becomes hard and brittle, the Luschka joints can become affected as well. It isn't one or the other. Okay? That example of what it looks like. Now we're going to the lateral. But notice on the lateral we're back to 72 inches. So I physically moved the projector back to 72 inches. So the 2 inches in the chiropractic world or in the radiology world are 40 inches or 72 inches. It's one or the other. So the first two were done at 40. This one is done at 72 inches. But if I tilted my tube for the AP lower cervical, I've got to get this thing back to perpendicular to the X-ray or film device. So that's why we say no tube tilt. We're back at 72 inches. And what you're going to find is when you go back to 72 inches, this lit up area becomes so much bigger. So we have to make adjustments to our area that's exposed. Harder to talk about it than it is to show you. The central ray goes to the thyroid cartilage. So I simply say to my patient, stand like this, put your finger on your Adam's apple like so, and then I aim, I lower my tube the way I need to, so that the X is casting a shadow on my thyroid cartilage. Okay. Did you ever have a cervical spine X-ray done, sir? X-ray cervical spine?
I have.
Okay. I don't know if they did the same routine or not, laying down or standing.
I did both.
Both?
Yeah.
Okay. All right. So we're gonna do by choice, most of our standing, we can do, we come and use, but, okay? It's always at the thyroid cartilage. Okay, if you have big shoulders, like your biggest student here, okay, that's you, all right? You wanna get rid of the traps, you can either say to the patient, pull your shoulders back, or you can have them sit on the stool, and by then pulling on the stool, that pulls the shoulders back. And forget number 3, because if you hang on to the weights long enough, you'll be down, and then all of a sudden the traps will come up like so. Okay? Short students, you're going to have a challenge with your largest standing patient, so get him to sit down on the stool, and we'll show you how to do that in the lab. Okay?
That's right, sit down.
So from the side perspective, we're always interested in our vertebral body. This is a singular one, but I want to remind you that the body is superior cortex, anterior cortex, inferior cortex, posterior cortex. This is what? Transverse process. What runs through the foramen intertransverse area? Neurovascular bundle. In particular note is the vertebral artery. Okay?
Yeah.
Now, if you see calcification in this area, that's vertebral artery calcification, but you're more likely to see calcification anterior to the vertebral artery. That's more commonly carotid sinus calcification, and that is very common, and that comes in when we talk about classes, what it looks like. Okay, so the schematic, first cervical vertebrae, second, and so on. Notice that our anterior aspects of the vertebral body are here, but this is the angle of the mandible. So on the lateral examination, we say to the patient, let me just push your chin out ever so slightly to get this margin away from the cervical vertebrae. I need to see the cervical vertebrae precisely so that I can make a good decision about is there or is there not an odontoid fracture present. Okay? Now, what did we just talk our way through? How to set up a patient for all those 3 views. I didn't do it deliberately, but I went fairly quickly. What did we start with first?
A to P, up and down.
No, okay, fair enough, but what did we start first? Patient preparation, right?
Yeah.
So while you're deciding where I need to be, you're saying to your patient,
Can you take off
all the metal
this?
objects. Okay?
Are you
Now,
pregnant?
that routine is your routine. You may not like how I've described it, okay? You can start however you want, but on our first two views, what SID should I be at? 40. Okay, if you're at 72, because the last person left it at 72, you have to realize you want to be back to 40.
Mhm.
So those are the kinesthetic things that we have to remember while it's my turn. And on Thursday, you've never been in the rad lab, so there's all kinds of new buttons and toys, and we just work our way through that. Okay? All right. These are cervical lateral spine x-rays. Anterior tubercle, different patient, this is posterior tubercle. All right? 3, 4, 5, 6, 7. These are not normal. So us determining things is called our search pattern. We'll show you how to do that. But look, if I just draw a line down my anterior body line, vertebral bodies, come back to the posterior portion, and then I come to my spinal laminar line, okay? Is this spinal laminar line different on this x-ray compared to here?
Yep.
It is. How is it different?
Spacing.
Space, curvature, okay? But what's this?
Posterior arch.
Posterior arch. Is there a posterior arch here?
Nope.
No. This is congenital. This person was born with no posterior neural arch. Okay? Live patient. In other words, not from the internet. Collected this from somewhere. Okay? What does it mean to you?
It exists.
It exists, good. What else?
Potentially dangerous if they
Potentially
were
dangerous.
to fracture their C2.
Or at risk, right? Do I want this patient to go skydiving?
No.
Toboggan?
No.
They're at risk. Okay, they don't have the osseous protection around their neural canal that someone who has this posterior neural arch. Okay? So look how easy that was. We simply did some basic search pattern analysis. Anterior body line, posterior body line, you may have missed it here, but if you got it on the spinal laminar line, you would have seen it. Or if you did a segmental analysis, anterior tubercle, top of odontoid process, this is where my lateral mass of C1 is. Oops, I get here, where the laser pointer is, it's missing something. What's it missing? Compared to this is my normal. Hey, it's missing a posterior neural arch. Now tell me you can do that while you're at lunch between 12 and 12:50. No, it takes some time to do that.
Mm-hmm.
So here's what we're up against. You treat patients all day. When are you gonna do your RAD reports? What's left? Morning before you start, lunch, or at the end of the day? What's the problem with that? I don't wanna get up at 7 o'clock in the morning. I wanna have lunch. I don't wanna do the RAD report. At the end of the day, I'm exhausted. I wanna go home and have a beer. So now you put off your RAD reports. Okay, and it's how the mistakes happen. Okay, it's gotta be dedicated time. The more detailed your search pattern is, the better you get at it.
I have a question.
Yes, sir.
So you have a left marker on that patient on the
We
right hand
have.
side?
Yeah.
The
I said
patient-
all x-rays needed to be marked, right?
Yeah, but does that mean that you're just looking at the patient's left side going in?
The x-ray goes through, they've arbitrarily said the patient's left side was against the board when they took that.
Got it. Because it wasn't making sense to me.
Right. Now, I said all x-rays need to be marked.
Yep.
If you're ready for the exception is, it doesn't have, the laterals don't have to be marked.
Got it. Thank you.
Okay, but if that's too difficult for people, then I just say, forget about it, mark everything. And if I'm standing like this is my right shoulder, mark the side that's closest to the film, and vice versa. Okay, because that's the convention we all understand. On this one, normal, normal. How is this motor unit different than 3-4? It's different because this vertebral disc space is different. This has a margin to it. This looks like it has either a straight margin or a little bit of a concavity. And then these are joint spaces. There's no joint space here. This patient, again, was born with this defect. This is what's called a block vertebral body. It's probably in the cervical spine, it's the most often seen normal variant by me in all the x-rays I see for clinic films, chiropractic films, et cetera, et cetera, et cetera. Now, why is that important? Girls know why, because they were here last week, and I'm not throwing everybody else under the bus. It's important because if you have no joint space here, what happens when you manipulate?
No fluid?
They're gonna press on
Oh,
vertebral
yeah.
artery.
No, the vertebral artery is
I mean, it's more anterior. but-
anterior. But if I have no joint space, can I get manipulation?
No, no cavitation.
No can do, right? Because this is not fused, it never is separated into a true joint space at birth. It's not going to move for you. Chiropractic physicians have tried, and what has happened? Pain, pain, pain. So then the patient says, well, when I went to Dr. Smith, there wasn't any pain because Dr. Smith was careful enough to realize this was blocked, or not segmented, or segmented, and the spinous processes were fused too, because this distance is different than this distance. Okay? Now, we're to show you view. If you're not sure, the answer to it is do a flexion view. And on the flexion view, there's not gonna be any separation. That's proof positive that what you saw is real. Okay? And my suggestion is don't manipulate 5-6 motor unit. Nothing's gonna happen except soreness. And then as the patient progresses from this date to age 30, is it possible that because this is not moving, there are issues elsewhere? We keep talking about relative hypermobility in areas that aren't fused, right? Now, I don't know what the literature says about blocked vertebral bodies going forward. It's case dependent by mine. Some of these patients develop disc disease at this level, some develop disc disease at this level going forward. When they start saying, I've had good luck with chiropractic care, but now I've got pain down into my right arm, that's the clue for you that something is going wrong. And they may need a MRI examination to evaluate the disc space. In other words, this x-ray is giving us information at this particular point in time that is useful for our therapeutic intervention, no? If it doesn't do that, the question could be asked, why did we take it? Okay? And I'm a big one on, this is agenesis. Are there x-rays 5 years ago? If there are, I would want take a look at the x-rays from 5 years ago and see if it was there. Maybe somebody missed it 5 years ago. Maybe there was no reason to x-ray it, but now you have to deal with this particular problem at this point in time. Okay? 3, 4, what's happened at 5? This is what surgical intervention looks like when they do a fusion of your 5-6 vertebral body. This vertical is a replacement intervention to the disc. I put the 7 on so we wouldn't have to waste a whole lot of time. But this is very common. That's how they fix neck pain when they can't manipulate anymore. Okay? Now, how do you know? If you didn't see the x-ray, how would you know that this patient had surgery?
Ask.
Ask? Yeah, they did something to my neck 10 years ago. I forget what it was.
Actually feel it.
No, you could feel it, but what's the first thing you're gonna do? You would look at it, right? You inspect. There's a big scar there. Aren't you
Hmm.
interested in what the scar is? Oh, yeah, I had something done to my neck. Now they don't know. Take an x-ray and you see this. That's what intervention looks like, or one of the ways to cause this. Again, we're dealing with this at this particular point in time. I know for sure they can't have what diagnostic imaging test done to them?
MRIs.
MRI. Okay? Now, I need to know, I think I would wanna know whether they have relative normal motion or not. This is a candidate, I think that needs flexion and extension. This may fail. This has already developed degenerative disc disease at 4, that's what this is, or that may be post-surgical MS. This disc space is not normal, it's decreased. I don't know when they had previous x-rays, but that's not normal. So they're already going a certain amount of instability because of their surgical arthrodesis. If they're 45, they're gonna be with you for quite a while. Okay? So an example of what you can expect to see in clinical practice. So we've talked about this, okay, and I've given you the challenge of how do you organize your steps, and you'll feel differently about it once we're in the lab touching each other and trying to position properly. Okay? So back to our story, I'm changing the diaper on the baby, right? Okay, you said we all needed what? Baby. Somebody said, grab the diaper. I said, well, maybe I want to put him on his back first. In other words, our steps are different, but at the end of the day, I should have a brand new baby with a clean diaper, right? How you got there is not nearly as important as working from A to B in a logical, systematic fashion. And you'll change your methodology. You'll find out once you have the pee in the face, you don't want to do it the same way again. Okay?
Mhm.
So this is one of my favorite pictures because semester 5, semester 6, 7, 8, 9, 10, DC, master, but there's one little stone missing, that's healer. We want you to get to the healing stage. You never stop learning. Remember the Dr. Birnbaum taught his obstetrics and gynecology, and I asked him on graduation, what's your recommendation, your advice to me? Never stop learning. It's been that kind of a journey ever since, for me. Now, I got my DACBR in 1992. Are you gonna be able to catch up to me? No. Can you use the basic principles that we're trying to instill in you to save yourself an awful lot of time and aggravation? Of course. Okay? So the process is the same. So when we show you, talk about why did you ask for the MRI, there's a basic framework of information. In other words, once you realize that the chaos, the order out of the chaos is the same, and we're creating the same trail, you just follow the same trail until you get the results that you want. Okay, it's not hit or miss. Okay? Cervical spine positioning is cervical spine positioning, but we'll go through the same steps, 40 inches or 72, when we do lumbar spine work. Okay? I can show a chiropractic assistant just out of high school how to take x-rays in 4 weeks in North Carolina, because I've done it so many times. Okay? But what are my expectations of her different than my expectations of you?
Yes.
Absolutely, because you're the critical decision makers. The positioning is easy peasy. It's the decision making and recognizing what's abnormal or normal on the film that will separate you from anybody else. And you only get as good as you want to get. Okay? Now, I'm not saying you have to study radiology 24/7. No, that's not it. But once you understand there's a method to the madness, your lives become dramatically easier. Okay? All right, that's enough for today. Have a good